So this is a video on local anesthetics, pharmacology part. This should be the part 2 of spinal anesthesia or local anesthesia. So in this part we will just study about the pharmacology of the local anesthetics. So under LAs, first we will see the classification. So classification is based on the structure, which is not much important, just know the basic. So when structures can be amides or esters. So use this trick. Amides will have two eyes like lignocaine and bupivacaine. Esters will have only single eye, procaine and chloroprocaine. This is not much important. This one is more important than above. So based on the duration and potency, short duration or low potency and low potency is chloroprocaine. Intermediate duration and potency is lignocaine. Longer duration and high potency is bupivacaine. Then we come to mechanism of action of local anesthetics. So we know that during normal nerve conduction, when the action potential comes, then the sodium channels gets activated, sodium goes in. Also the sodium potassium pump gets activated, which throws out potassium and brings in sodium for the conduction of the impulse. So all the LAs, they block these sodium channels, okay, and they also block the potassium and calcium channel, but predominantly they block the sodium channels. So the entry of the sodium is stopped and the nerve conduction is also stopped. Okay, so then after injecting the drug, depending on the surrounding pH, the drug will dissociate into non-ionized form and ionized form. So you know polar molecules are water soluble, so ionized form is water soluble, so it won't be able to go inside the nerve cell. But non-ionized form is lipid soluble, so it will be able to cross the lipid membrane and go inside the cell and block the sodium channels. So what happens is, the active component is the ionized form, but the component which will cross the lipid membrane and go inside the cell is unionized form, okay, non-ionized form. So normally what happens is, this is our cell membrane, the outside cell pH is 7.35, okay, and the inside cell pH is 7.34. so outside the most of the drug is lipid soluble, so that is non-ionized, so it will cross, and inside it will, due to this slight decrease in pH, it will get ionized, which will produce the action, okay. So what happens in, this is normally what is occurring, but in cases of like this pus formation, necrotic wound, dirty wound, what happens is that the outside medium is acidic. So the outside medium is acidic, so the most of drug will become ionized, so it won't be able to cross the lipid membrane and there won't be much effect of the local anesthetic, so patient will still complain of pain. So this is an example for this, like for in a tooth abscess, the dentist, what kind of anesthesia will use? Inferior block, general anesthesia, monitored anesthesia, continuous monitored anesthesia, or none of the above. So normally they use inferior block, but as this patient has tooth abscess, so due to the abscess, the pH, surrounding pH is decreased. So as soon as we inject the drug will get ionized and won't be able to enter the cells and won't be able to show its action of sodium channel blocker, and thus there won't be no anesthetization. So for this question the option will be general anesthesia. We don't use continuous monitored anesthesia in this patient particularly because this is a patient of tooth abscess, so this patient cannot be intubated properly via the LMAs, so we cannot use the continuous monitored anesthesia. Instead we will go for general anesthesia, and but practically what we do is, we will give antibiotic regimen for 5 to 7 days, which will reduce the abscess and the infection. Then we will give the usual blocking. Then there is one important pathway is sequence of nerve blockade. So don't go in that much physiology, just remember this. For spinal anesthesia, what is occurring, or for local anesthesia, this is the sequence. of anesthetization, first autonomic, then sensory, then motor. Okay, so after giving anesthesia we will wait for 1 to 2 minutes and then we will ask the patient to lift his leg. Okay, like if we are giving spinal anesthesia, so this is the sequence of autonomic blockade, sequence of nerve blockade, autonomic, then sensory, then motor. So after giving after giving the spinal anesthesia we will see a fall in BP because the autonomic system will be, and in this autonomic mostly will be sympathetic because we give in the lumbar region, so thoracolumbar is sympathetic system, so that will be blocked mostly. Okay, so we will see fall in BP and heart rate, then the sensory will go, then the motor will go. So after giving spinal anesthesia we will usually ask the patient to lift his lower leg without bending at the knee because the glutes, because the quads will be anesthetized later. So we'll ask the patient to lift his leg, so he will complain of he will complain of feeling heavy limb or tingling sensation. Then we can confirm this by sensory, like we can use a needle or a pen and we can rub on his chest, abdomen to see up to which extent there is anesthetization. The sequence of recovery is reversed, like motor was anesthetized last and it will gain recovery very early. Then comes the clinical pharmacology points. So the onset will depend on the concentration. So concentration, if the concentration of the local anesthetic is high, the onset will be quicker. It is nothing to be remembered, nothing that much like conceptual, it is basic stuff. Then action of lignocaine is faster than ibuprofen because lignocaine is short acting, lignocaine is intermittent acting, and this is long acting and high potency. So those who work for short will have fast action. Then LH don't work if surrounding pH are acidic, okay, known. Then comes to additive. So there is lignocaine plain and lignocaine plus ADR. So lignocaine plus adrenaline, this adrenaline will cause local vasoconstriction and the systemic absorption will decrease. So we can use more dose of lignocaine plus ADR and less dose, like if we use 3 to 5 mg per kg of plain lignocaine, we can use 5 to 7 mg per kg of lignocaine plus ADR because ADR will cause local vasoconstriction and the systemic absorption of the lignocaine will decrease. Then this thing is not that much important. So if you want to further quick action, like if you like very fast onset of action, we know that acidic surrounding pH will decrease the absorption because it will convert it to mostly ionized form. So we can use sodium bicarbonate, which is a alkaline agent. It will increase the surrounding pH, so the non-ionized form will increase, which will easily cross the membrane and the onset will be quicker. Then comes the absorption part. So for spinal anesthesia, onset is quicker. It is less than 5 minutes because it is in the CSF. So it will absorb quickly by the nerves. But brachial plexus block, we inject, then the local anesthesia has to cross the sheets around the plexus. So it has a delay which is 10 to 15 minutes. So remember this and don't like inject again and again in the brachial plexus block. You should remember this time. For spinal anesthesia it is less than 5 minutes. For brachial plexus block it is 10 to 15 minutes. Because the absorption depends on the site of injection. If you inject far, it will take more time. In spinal we are injecting directly into the CSF, so absorption is faster. Similar here, IV anesthesia is really fast because we are injecting directly into the blood, and brachial plexus block is really slow. Okay, by adding vasoconstriction absorption is okay. And in pregnancy, due to hormone progesterone, nerve fibers become sensitive to LS. So a low dose of anesthesia will give us the same effect. And if we use the dose as we use for normal individual, we will see that there is more anesthetization than normal person. Then mixture of LAs. So onset is quicker and duration is longer. For that we can use chlorprocaine plus bupivacaine. So chlorprocaine is a short acting, bupivacaine is long acting. So chlorprocaine will give quicker onset, bupivacaine will give longer duration. But disadvantage with this is that crosses maximum threshold leading to allotoxicity. So we so basically we are increasing dose of the local anesthesia. So for a lower total amount, they will cause toxicity. Then deciding the dose of local anesthetics, we will have to use these three things: concentration, doses, and volume. Concentration is like 5%, 2%, 1%. Dosage is like how much of we use, like we use 5 ml of 2%. Then the volume, did we dilute it or not? Like we can use 3 ml of 1% lignocaine and give it without dilution, or we can have same effect with 3 ml of 2% lignocaine but diluted with 3 ml of ANES. So both will have same effect. Then comes to the doses. So you have to remember this. This is the must part. Lignocaine maximum dose is 5 mg per kg. Lignocaine dosage is 3 to 5 mg per kg. For ADR, vasoconstriction will allow us to use more dose. Then maximum increase to 7 mg per kg. For bupivacaine, it is 2 to 3 mg per kg. Now comes to concentration. For minor nerve block, like for radial, ulnar, and local blocks, we will use 1% lignocaine. For plexus block, brachial, sacral, we can use 1 to 2%. For spinal, we can use 1.5 to 5%. For bupivacaine, for local minor blocks, we will remember lignocaine is more important. Bupivacaine is mostly important for spinal, and lignocaine is more important for minor and major blocks. So remember these three. These three are must. Okay, but if lignocaine is not available, only bupivacaine available, you should also know these: 0.25 to 5, 0.25 to 5, same, and here 0.5 to 0.75. Here 1 to 2, and 1.5 to 5. These three are must. Then comes there's always do the concentration of the local anesthetic, use required amount. So like this is for surgical scenario, like there is a secondary suturing, or there is a laceration that need to be suture, or there is a wound development to be done. So we take a local anesthetic, we bind the needle and inject in the surrounding area. So there what we can do is, for this is not that important, but still to reduce the chances of toxicity, we can decrease the effective dose. Like if 1% lignocaine is enough for local concentration, because see here, for minor block 1% is enough, but assume we have only 2% lignocaine available. So what we can do is, we can take 2% lignocaine 3 ml and dilute it with 3 ml NS. It will give us 1% lignocaine 6 ml. Okay, so this will decrease the chances of toxicity. So now comes to toxicity. What happens if the lignocaine is given more dose? Then it will enter the blood vessels, it will go systemic. So what are the local anesthesia systemic toxicity? First is so it will affect mainly CNS and CVS, because they are dependent on sodium channel conduction. Other systems are not that much dependent, because the mechanism of action of LA is sodium channel blocker. So they will affect mostly these two systems. So on CNS, what happens is, lignocaine is the more notorious for CNS toxicity. So lignocaine injected intravenously, or it went intravenously because we injected it wrong, or we injected in more dose. So it will cause, first it will cause lightheadedness, then circumoral numbness, then tinnitus, then visual disturbances, then muscle twitching, and finally it will lead to GTCS. So remember lightheadedness, then remember vision disturbances, then muscle twitching, and then GTCS. Okay, this is the sequence. And treatment for GTCS is, we will give anticholinergic, that is short acting benzodiazepines like midazolam, which is better than diazepam. Then second thing we will do is, we will intubate using thiopentone, propofol, and muscle resection. Like we were giving LAs for a regional block, okay, or a spinal block, or local anesthesia, but now patient has gone to toxicity, so we cannot manage the patient in the superficial planes of anesthesia. We have to take the patient in the deeper planes of anesthesia. So after giving anticonvulsant, we will convert the LA to GA, so that we can manage patient with our drugs, which will be easier for us. So we will intubate the patient using thiopentone, propofol, and any muscle relaxant. So then we will continue the mechanical ventilation. So there are two things now. First is, like, if the seizure doesn't stop after midazolam, so we don't have to go in the management of things like status epilepticus and give them phosphonate and other things. Instead, use thiopentone as an induction agent, because thiopentone is a very good induction agent and a very good anticonvulsant. Then one addition in the mechanical ventilation is, like, if we hyperventilate the patient, like we set the respirate rate in ventilation more than 16, like normally we set it 14 or 16 or that much. If we set it to 20, then there will be hyperventilation of the patient. What will occur now? Hyperventilation will cause decreased PSA2. What will that cause? It will cause decreased cerebral blood flow, and now the LA has entered systemic blood flow, but due to decreased cerebral blood flow, now the less amount of LA will go to the brain, so the CNS toxicity will be less. Okay, so avoid such situation by remembering the dose and concentration of ligno and BPO. That remembering these, this is dose and this is concentration. Remember these to avoid such conditions. Then come to CVS toxicity. So in CVS toxicity, all LAs will have a negative inotropic action. That is, they will go, especially they will affect the Purkinje fibers. What will happen then? Increase PR interval and QTC interval. Patient will land in ventricular arrhythmia. And this cardiac toxicity and that is ventricular arrhythmia are very resistant to treatment. Okay. So lignocaine was more notorious for CNS toxicity. bupivacaine is more notorious for cardiovascular toxicity. Okay. So bupivacaine. So the treatment here will be stop injecting the drug and start CPR. Here was also, as soon as you see the symptoms, stop injecting the drug and manage the seizures if seizures are present. Here in CVS, stop injecting the drug and start CPR, because these arrhythmias are very resistant to treatment. So in CPR, we will give the compressions and the breaths and keep the defibrillator ready and use accordingly. Then another drug that is available for cardiac toxicity is 20% intralipid, which will bind to bupivacaine and prevents its further action on sodium channels. Dose of this 20% intralipid is 1.5 ml per kg bolus followed by 0.5 ml per kg per hour infusion. So this is how ECG with ventricular fibrillation will look like. Okay. Then this is the very important part also. Like we have seen that we use lignocaine plus ADR for local administration in like injuries or small surgeries in minor OT for suturing and dressing and all the debridement things. But lignocaine plus ADR is contraindicated in these places, such as was finger, toes, ear lobule, tip of nose, circumcision, because all these have end artery supply. So there is no other supply to these. So if we inject LA here with adrenaline, what will adrenaline cause? It will cause vasoconstriction. So this part will not receive any blood supply and it will go into gangrene. So instead we should, if you want to use, just use plain ligno. So instead of ligno plus ADR, instead use plain ligno. Okay, then comes the painless IV cannulation. So it is not of that much use, but it is useful. Like there a psychiatric patient which is aggressive and non-cooperative, or there is a child which is non-cooperative, and there has been multiple attempts for IV cannulation, but there is no successful IV cannulation. Like the nurses have tried, then the interns and PGs have tried. So the cooperation will decrease, the shouting, pain, aggressiveness will increase. So in that condition, we can use this EMLA cream, which has lignocaine and prilocaine. So just apply with anything, like with any occlusive dressing, not like some bandage, because it will go through that bandage. Anything like you can use micropore, you can use the fiberplast fiber tape, or you can use any sticker. So apply the area where you want to cannulate and leave it for 30 to 45 minutes. Then come back and you can easily do the IV cannulation. Then there is Bayer's block. So Bayer's block is not that much important. Okay, so we are done with this. So let's have a just quick review of Bayer's block. So what do we so Bayer's block is named according to scientist Bayer's. So what he did was he will inject the LA intravenously into the forearm after the application of tourniquets. Okay, so he'll apply the tourniquet on the arm, inflate them, and then inject the LA into the veins of forearm. So what happens is the LA will spread through the veins of forearm. It won't be able to go systemically. It will just spread into the veins of forearm and arm, which will give full arm anesthetization. So it is a like replacement for, instead of giving brachial plexus block or radial ulnar block, all them, just you can use this Bayer's block for a particular limb anesthetization. So you have to remember this. The tourniquet pressure should be set to more than 250 mm Hg or 100 mm Hg above SBP. Like if the patient hypertensive, maybe he have SBP of 200, then you have to set 100 mg above SBP. Okay. And if the patient is normally at 140, then obviously it will go to 240. Okay, so remember this one. SBP should be 100 mg above SBP. Okay, so what will this help in? That this venous flow won't go systemically. So the arterial blood will be able to come through the arteries, but the venous drainage will stop. So obviously this venous drainage stop, so it cannot be used for longer surgery. So it is only for day care and short procedures. So first what we have to do is, before giving Bayer blocks, we have to do these two things. First is secure IV line on the opposite hands for emergency condition, like for due to any reason the venous drainage occurred and there is systemic toxicity. So we should have a IV line secured on the any another hand or limb. Then second thing to do is we should use more than one cuff, like we should more than one tourniquet. Okay, and inflate them. First do these two things, then only you can inject the intravenous LA. So it is indication is day care and short procedure, not used for long procedure at this risk of nerve compression and injury. Okay, so this was precautions is make sure the cuff don't deflate, and that is why we are using two cuffs. So use two cuffs. Then do not remove the cuff, do not remove the block suddenly, let's slowly deflate it so that the drainage is slow. Bayer blocks is not that much used, but just know a little bit about it. So this is the pharmacology part of local anesthetics. Spinal anesthesia and brachial plexus block is discussed in another video.